library. However, the preferred practice patterns are no longer used, and I don't know why, but they decided that they're gonna put everything into a preferred practice pattern. And you'll understand a little bit more what I mean by this when we start doing modalities, because in your modality book, which I encourage you all to buy, because modalities are very difficult, they will show you preferred practice patterns, which kind of leads you thinking on the way that you should be thinking, as well as evidence-based practice. So when we talk about evidence-based practice, we say we're doing something for a reason. You know, years ago, when I first started, 100 years ago, good last guys. It was, we would do things like, okay, you're going to do an SLR 3 times 10, right? You probably still hear that out in the clinic. 3 times 10. Well, 3 reps, right? 10 times 3 reps. Who came up with that? Was it just something that was kind of grandfathered in? You know, so now everything, and we go to the APTA, and those of you who are APTA members, and as a student, it's a lot cheaper to be an APTA member than as a faculty or as a PT or a PTA. I believe, I don't know, Oscar, you should look into that. If I get some information, I will provide you with it. Usually they send me stuff. I think it's $50 or $60 a year, and with that is the ability to attend classes, continuing ed classes. I mean, and you don't have to be a PT or PTA to attend. You could be a student to attend continuing ed classes. And your classes, for example, mine might be $595. The same class for you may be $100. You know, and I'm not saying that that's cheap because you're a student, but it's a lot cheaper than we would pay. If you also, Professor Maley will be talking to you about this in probably the 5th session, the last session, that there are meetings. There are chapter meetings that go on. And at some of these meetings, an annual meeting, that we encourage you to attend, and we'll provide you with that information about where they are, et cetera. But if you're a PTA, a PT member, you'll get that information. But there are chapter meetings where they have poster presentations and different research that's going on, as well as breakout sessions for continuing education. And it's pretty much maybe $60 for you guys or something like that. And some of the other things are free. So I encourage you to get involved in the association. Oscar, has anybody reached out to you from, because I know if I get it, I forward it on, from president of the PTA, student PTA organization?
I don't think I've received anything.
Or any of the PT organizations, they're the president associated with the PT, no?
No, I don't think so.
I'll follow up and see if because as soon as they send something to me, I usually send it to you and I'll discuss it with Professor Maley. Okay? So were we okay last week on what we discussed? Yeah?
Yeah.
Was it enlightening?
Definitely.
Okay. So Kev, you wanna, and I know you guys were provided with 2 scenarios and you never got to the second. So did anybody look at it? It's okay if you didn't.
Yes.
We'll do it now. Jay, you looked at it? Good girl.
Yes. Yes, a good girl.
I thought Casey for sure would say, oh, I looked at it, I read it, I wrote all the answers, I know everything there is to know about it. Him and Chris.
Well, actually, I thought about this. I didn't look at it because if I took 2 hours to go through it and search all the answers and whatnot, that's not realistic to a scenario where I'll be presented with it and I'll have about 15 minutes to look at it. So I didn't want to waste it.
Yeah.
Right. Okay. So Kevin, you want to?
So I've shared the document. You guys have access to the document that I shared with you. So just as a reminder, I put up there are 4 questions. We did the first one already. So what I recommend that you guys do again is that you make a copy, right? So just to reiterate, we look at the top of this, we go to file, make a copy so you have your own copy that you can write on, right? right into it. Yeah.
All right, I'm sorry, Kevin, before we break out, do you remember, and And I'll repeat this next week too. But do you remember the difference between the Navy model and the ICF? Because there are all these, and it gets confusing. And a lot of facilities, honestly, as much as you are in school, don't use the terminology, but I think it's important to know. And they do ask some questions on the state board about abilities versus disabilities. Do you remember anything I said last semester about the Navy versus the ICF? When we talk about soap notes. When we talk about, like, not soap notes so much, but choosing some information that's provided in the chart. Anybody remember? Is it too early?
I remember hearing the words, but I don't remember.
Yeah, I'm familiar with the word Navy, but not.
Didn't you mention one has relates more on function and the other?
Okay, one who relates more to the ability, because anything that somebody can do is an ability, right? As opposed to a disability. So what's the difference between saying someone has an activity participation of ambulating with a walker, as opposed to the activity limitations require the person to walk with a walker? What's the difference?
The
One
first
has
one
more-
is stating like what the person is able to do. The second one is saying what they're not able to do,
Right.
what they need to do.
Right. So if we think about this when we talk about a patient, which one has a more positive connotation and which one has a more negative?
The first one has
Yeah.
more positive.
ICF talks about a patient more positively than the Navy model, which talks about somebody who has a disability, right? So that's the kind of, this is where we're going. And I know they sound like words, but this is the way we're going with trying to look at patients in a different way. Does it change the way we treat someone? No. The big thing is that one of the big things that changes though is the fact that we don't signify or choose a patient and say that's the patient. And I said this last week also. That's the patient with the knee. We're in room 202 is the knee patient. It's the patient who has a diagnosis of the knee osteoarthritis. It's not the patient with the knee problem. Okay? So the patient is a person and they have a specific diagnosis. But we don't just say the back patient in room 202. So we try to get away from all that kind of terminology.
Professor, does that mean we're trying to word both in, I guess, documentation as well as the way we express ourselves for more positive outcomes?
Yes.
Okay.
Yes. Okay, because as we will talk about when we talk about ADLs and IADLs, some people can do some and other people can't do others. And that's one of the questions we have today. I won't tell you because I want you to look it up and then discuss it, and then we will discuss it. Okay? All right, Cass, you want to put the second question up?
Yeah, so I mean, we have the, you guys should be all able to access the Google Doc with the questions. And I mean, if anyone has any problems, you can just send something to me in the chat. So what I'm gonna do now is we're gonna basically do what we did last week, where we kind of break you guys up into groups. We're gonna give you some time. We're gonna do it with a little more of a time constraint than last time. Last time you guys had a bunch of time. I'm thinking for this situation, for this question that I want you guys to do, and specifically, I want you guys, Dr. Stutz, do you want them to start with question 2?
Yeah, it doesn't matter, whatever question, we need to get through these. So,
Okay, all right.
You put up, we'll do.
All right, so let's start with question 2. You guys are going to have roughly about 30 minutes before we come back together and discuss. So I'm just telling you guys right now, then Dr. Stutz and I will be filtering in and out of your groups to help you whenever you need it. So I'm going to put you guys in the breakout rooms.
Yes.
There? All right. So what can you tell me?
He may not, was he in on the discussion? He may not have been on the discussion.
Who?
No, I think Kevin said Jasmine.
I'm sorry.
Yeah.
I'm sorry. Okay.
Yeah. So Jasmine, what did you guys say? Like, describe the body system responses to hypothermia. What did you say for the first question?
We have a couple. We said shivering, piloerection, vasoconstriction, decrease in sweat gland activity.
Vasoconstriction of what?
But before you even say this, before you even answer that, I think that maybe we're going to think about that answer for number 3.
Yeah, we have that for 3.
Okay, so what, does anybody else have anything for, I'm sorry, Kev, I'm sorry.
That's okay.
Okay.
For number 1. So what is it, how is the body system responds to this hypothermia? What happens, that's what this question is asking. What happens when we're hypothermic? What happens? You know, as our body will respond in a certain way when our temperature drops down. And that's all the other stuff that you've just talked about. But what happens?
Your heart rate will start to decrease.
Respiratory rate goes down.
Your
Okay,
body
so
temperature
what would we-
decreases rapidly.
What would we refer to that as? A decrease in what? If we're saying the heart rate decreases, we're saying
Orthotic activity.
the overall metabolic rate, right? So we'll get a decrease in the overall metabolic rate.
Okay.
And the body temperature, what happens to that?
Core temp decreases too
Over
with
time,
hypothermia.
and over time, the temperature will decrease, right? But didn't we talk about the fact that we have, what are we normally, 98.6, but there's a range, 97, 90, right? Depends on what the person has and what morbid conditions the person has. But normally, we have a set value. So what happens? As we get towards the cold, the temperature starts to drop, yes?
Mm-hmm.
Anybody else?
Is there like a specific number approximately where you start to say we have hypothermia?
95 and under.
Okay, 95 and under is when we start to have hypothermia, and then there's a range. But what's the bottom end of the range when you have a lot of big problems?
90.
Like anything under 76 almost.
85.
Well, I would say we want to go with like.
I'm sorry, Joe said it, I think. What'd you say, Joe?
Ooh, nice. So we wrote down the 5 stages. I mean, stage 1 was 95 and under. Stage 2 was 90 and under. Stage 3 was 83 and under, and then stage 4 and under would be like 76.
Well, what did your book say? Do you remember a complete loss of temperature under, or a complete loss of temperature below 85 degrees Fahrenheit, right? But we did also say that there are things on record where somebody had a really, really low temperature and was still able to survive.
Yeah.
So,
Yeah.
the body,
So it's kind of like 85 is like the bottom end that you want to think of. 95 is where it starts. 85 is where we're saying like when you're below that, you're in severe hypothermia at that point. All right. Let's see, Dan. For number 2, what are some of the symptoms of hypothermia that this patient is presenting with?
Well, we kind of talked about it already, but decreased respiratory rate, heart rate, blood pressure is all out of whack.
What's normal blood pressure?
Is it 120 over 70 or 120 over 80?
Yeah. Okay.
Oh, no, it's not. Oh, okay.
Okay.
what about the skin?
One more time.
Integumentary system, skin?
Like the temperature of your skin? Oh, I have no idea. I have no idea what the temperature is supposed to be of your skin.
Oh, no, I'm not asking for a number. Should it be?
Oh, no, it should not be cold. No.
Yeah, your skin gets cold, sure.
Yeah.
Do you get pale or do you get red?
Pale. You get pale, blue,
Blue lips.
Yeah.
yep. And then what else? Oh, he had what was the frostbite was starting on a couple of his fingers.
Okay. Yep.
How about sensation then?
Sensations decreased. Well, because everything's starting to pull back into the center of the body to keep warm. So he's losing movement and feeling for all of his extremities. Yeah.
Right. So you mentioned so that's good. So you mentioned the pulse rate, the skin, the decreased sensation, all of the stuff coming into the body. So what do you notice? So like one big thing is like, what do you notice about the reflexes?
Reflexes. One also said that he had absent deep-tendon reflexes.
Right. And does that seem normal? Is that normal to not have any reflexes?
No, that's not normal.
Right. So as all of those, as you're trying to conserve your body heat and stuff like that, you're going to lose reflexes. You're going to lose your motor function. So those kinds of things you want to mention as well, not just the respiratory rate.
Gotcha.
Sensation.
Where are you going to look for cyanosis?
Cyanosis.
Devin, you said you know?
Would that be the lips?
Look at the fingers, the fingertips.
Right, and I think, Joe, I think you said lips, yeah. Lips and fingertips, yeah. You're going to look for blue. In fact, if you ever notice, I did a neuro clinic for a long time, and the first thing that the neurosurgeon looked at is a patient's fingers to look at digital cyanosis. So you look at fingernails, you look at toes, you look at fingers, you look at lips. Yeah.
Kevin, for the absence of deep tendon reflexes, our group kind of looked into that a little bit more. And we, Rich said that hypothermia affects the contraction and relaxation time of that reflex, and that that could indicate spinal cord root or peripheral nerve root or muscle damage, which is kind of scary because it's affecting the central nervous system. So
yeah, right. So that's where would you suspect? At what level of hypothermia would you expect it? Would you expect that when the person's going from 96 to 94, or do you think it's when they're getting colder?
Probably when they're getting colder.
Right. This is where it's that 85 range or lower, and you're talking about you're starting to really damage a lot of things. Right. So yeah. Let's talk about number 3 then. I guess, Jasmine, this is where you were talking about number 3. So go back, review again. What were you saying for number 3? You're trying to talk about specific things that happen when someone is right in the beginning of hypothermia, or right when they're starting to get cold.
You were talking about, yeah. What were you saying?
I said shivering, goosebumps, vasoconstriction, decrease in sweat gland activity.
So hold on, I want to stop one thing. You said vasoconstriction. So you're saying blood flow to every part of my body is going to decrease?
Where specifically? What do you think? If we're talking about vessels, because we're talking about the vasoconstriction of the vessels, there's vessels all over, right?
Yeah.
Where specifically do you think?
Is the extremities? You'd lose there first.
Yeah.
So that would be the cutaneous vessels, right?
Yeah.
Okay.
Yeah. Yeah, so when you say vasoconstriction, you want to be specific, because if I just hear the word vasoconstriction, I don't know, are you saying that I'm losing blood flow everywhere? Am I losing it to my, peripheral, my extremities and my skin? You want to be specific. Anytime we're talking about, vasoconstriction or vasodilation, you'll usually see, you'll say the phrase vasodilation of blah, 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 or vasoconstriction of blah, blah, blah. And you need to know specifically what is vasoconstricting and vasodilating, because certain conditions involve vasoconstriction of, the cutaneous blood vessels, and then other conditions have vasoconstriction of other blood vessels. And so, in order to identify the difference of what's going on, someone can't just say there's vasoconstriction. You have to say, okay, what is being constricted? To be more specific.
Constriction is brain, heart, vessel, skin, right? Vasoconstriction. I'm sorry, I said vessels, muscles. I meant to say muscles. Brain, heart, muscles, skin.
Yeah. So you have vasoconstriction, cutaneous vessels. You said decreased sweat gland, shivering. Anything else that would happen? Yeah.
And we also wrote hormone regulation, so the adrenal gland, thyroid gland, epinephrine.
Yeah. So that's and what does epinephrine do? What does that trigger?
Adrenaline.
Right. And what does that do? Is that more like fight or flight? Is it more relaxation?
Fight or flight.
Yeah. So it's fight or flight or sympathetic.
Yeah.
Right? So the sympathetic nervous system is the one that is, predominantly involved with the fight or flight response. Okay? Brian, for number 4.
Okay.
Yeah. So patient is unresponsive and cyanotic. What is the most appropriate pulse to monitor?
Well, we kind of had a few, but to test, since all the blood is kind of going back to the central body and leaving the extremities, we wanted to test the dorsal pedal to see if the limbs are still receiving some type of blood flow. But we also wanted to compare that to the carotid artery to see if they were the same, if we had any pulse whatsoever. But
Ryan, can you just name that vessel again?
Dorsal pedal pulse.
Okay. We say pedal.
Okay.
Okay.
Mm-hmm.
And I'm just correcting you here so that we say appropriately in clinic the dorsal pedal pulse or dorsal pedalis, the dorsal pedal pulse. But you're right. You're right.
Would you also take a radial pulse then too?
But which pulse is better to take when there's? Do you think these heartbeats are going to be diminished? Do you think I'm sorry, I was in the middle of something.
That's all right, Dr. So Brian, you mentioned the carotid pulse, but what specifically did it say in the documentation about the carotid pulse? For this patient?
I'm not sure. I gotta look back.
Yeah, so
weak carotid pulse.
So it's weak carotid pulse, which means do you think even the carotid pulse is going to be easy to find?
No.
Well, no.
Okay, so all right. I mean, you want to look at the dorsalis pedis pulse. You're probably not going to find it because all of that blood flow is coming towards the center. You thought about looking at the carotid, but that's pretty weak. So now what? What are you going to look for?
Wouldn't
temporal?
Who said? Somebody said it. Andre?
Yeah.
Andre?
Wait, no, I didn't say temporal. I was gonna say apex.
Yeah, you don't want to look at guys. Think about like distance from the heart. My carotid is here. My temporal is here, right, or here, right? So that's farther away from the heart. So do you want to go farther away from the heart, or do you want to go closer to the heart to get the pulse?
Closer.
You want to go closer, right? And so what is that? Where is that pulse that you mentioned?
So that's basically the apex of the heart. So it's 5th and 6th rib by the sternum.
And that's what we do. If we can't locate a pulse in the periphery, then we need to go to the apex. We need to go to the apical pulse. So if there's weak heartbeats and we really can't assess it appropriately, we need to take the apical pulse. When else do we take the apical pulse? And what do we need to take the apical pulse with? Can we take it with our fingers?
No, you need a stethoscope.
Stethoscope.
Yeah. And why else do we take an apical pulse? To determine what? You guys remember from the other day? Why would we take an apical pulse? Other than the fact that we have these weak beats and we can't determine them.
Pulse deficit.
Yeah, just notice if there's a pulse deficit. And how would we notice if there's a pulse deficit? Because that would give us information about cardiovascular problems, right? And not specifically in this patient, I wasn't discussing, because in this patient, it's just going to be almost impossible to get his radial pulse. I'm just talking in general. We would need to do the radial, right? So one person does the radial while the other person does the apical. You both count, and then you both compare. Shouldn't be much different. You know, maybe just natural error of 1 or 2 beats, but shouldn't be a big difference. Should be the same. Okay?
Should we check the right side or left side, or it doesn't matter for apical pulse?
Left, generally.
Left side?
But you're in somebody like Stephen. Stephen, are you there? Stephen left.
No, I'm here. Sorry.
Okay. So Stephen, where's your heart?
On the right side of my body.
Really?
Yep. I mean,
That's crazy, man.
Wow.
You have to understand that there are anomalies. An anomaly is something out of the ordinary. So he has an anomaly.
Yeah.
The heart on the right side of his body is anomalous.
I wish I could have been there, Dr. Stutz, for the practical when we asked them to find the pulse and someone had Steve, and they'd be like, I can't find the pulse, and I'll be like, that's bad, guys. But,
So for someone that's unresponsive like that, and us not knowing what abnormality they have, is it good to just have a habit of finding both sides?
Sure. I mean, if you're gonna have to search for it. You know, a lot of times you're moving around and say, I'm not hearing anything. Go, yeah, absolutely. You know, that's not real common. So Stephen is special. Stephen also has, he shared with you guys last year that he had something at birth that had to be taken care of, and they were very successful in it, but as a result, as he's getting older, he's having some other situations going on, right, Stephen? Yeah, you're muted right now.
No.
Oh, well, we didn't hear you. I saw your mouth moving.
My shoulder impingement.
Yeah, shoulder impingement, because he's not getting enough over rotation. Okay, I'm sorry, I completely missed you guys when you were talking about hormones, too. We were talking about thyroxine, right?
They mostly mentioned epinephrine.
Oh, did they? So what does epinephrine and norepinephrine do?
So guys, what does epinephrine and norepinephrine do?
Epinephrine increases your fight or flight response, so vasoconstriction, increases heart rate, blood flow, blood pressure, and contractility of the heart.
So it increases blood flow to the skeletal muscles, right?
So it vasodilates.
Yes. Right. Yeah. So it vasoconstricts. It vasoconstricts blood to to your skin, to your digestive system.
The skin in your gut.
Yeah. Right. Because when you're fighting for your life, you don't need to worry about the burger you just ate. Right. You got to fight for your life. So that's why I keep saying, guys, you have to be specific about where vasoconstriction is, because different responses, different systems have different responses on your body. So Dr. Stutz, should I break them out again and have them do question 3 then?
Yes, that's a good question. Yeah.
Okay. All right, guys. So I'm going to break you out into a room. This is going to be a little bit more involved as opposed to question number 2.
Do you guys need a bathroom break?
No.
Need a coffee break, bathroom break? You're okay.
What I was thinking is we do question 3 and then give them a break.
All right.
Yeah.
That's fine.
All right, guys. So let me break you guys out.
I put out there medication, although I'm not sure if that will relate to this scenario.
Oh, yeah, sure. Why not? If you got any medication, that would give you some information, right? Mm-hmm. Right. What it said, does it make you feel better, right?
Mm-hmm.
What else?
And that's all we have so far.
Okay. All right, that's a good start. there may be some other things we want to ask for sure. So but it is a good start, Jade. Does anyone else have anything they can add?
We added like what are your recreational activities? What motions makes it hurt? How do you sleep? Are you on the computer a lot?
Why'd you ask the how do you sleep question, Joe?
Well, because I was just kind of thinking like how I sleep. If I'm sleeping on my side, or especially we're dealing with the shoulder. If you're sleeping on that right shoulder,
Yeah. Right. Okay. Good. So that is a very important question that you should generally ask your patients how they sleep. Because it may tell you some important information depending on what they tell you.
What's the really...
Actually, you should...
If you're sitting at night.
I was going to say, it doesn't... in the paragraph, it doesn't mention if he has had any past injuries or like surgery. So that's a good question.
So that might be a very important question to ask, for sure. Yeah.
But there's also a question that we as therapists always ask.
Another one that I would ask is whether or not they feel pain like normally during the day, to see whether or not it's like something like a bursitis or something else along those lines.
Okay. But you want to know, you always want to know where the pain is, right? So where do you feel pain? Now, does that give you a lot of information? Sometimes. Sometimes not. Sometimes not, because it can be referred. So it can be viscerogenic and it can be referred. But we certainly want to say, where is the pain? Where do you feel pain? You want to ask about, I always ask, what makes it better? What makes it worse? Okay? Because a patient may say to you, oh, it's there all the time. Think about, just for example, an HMP patient. What's going to make it worse?
Flexion and rotation?
Flexion and rotation.
So is this patient going to complain of pain getting up from sitting or just sitting?
Sitting could definitely hurt it.
Well, no, because if they're sitting, they may be comfortable. They may have a support behind their back, a pillow behind their back. They may be in this kind of a bit of a lordosis. They may be in a posterior tilt where you're not getting a lot, and depending on what size the size of the herniation is, compression of the nerve roots, but certainly getting up from sitting or going down from sitting, right? So maybe they don't have pain, because the patient will say to you, it hurts all the time. So you say, is there anything that makes it better? Oh, yeah, well, it doesn't hurt when I sit. When this person says, well, it doesn't hurt when I'm just sitting. I'm sitting at the table. It doesn't hurt then. But it gets worse when I do this, or it gets worse when I do this, or when I have to reach out. Usually a patient says something like that. So what makes the pain worse? What makes the pain better? I take a NSAID and I feel better. That's going to tell you what? You got an inflammatory process that gets better when they take medication. Right? Okay.
And when they say if they get pain when they're sitting or whatever, what else should you ask them? You should ask them, sit here. Show me how you sit at the table. Because then you might see, like Dr. Stutz was mentioning, maybe they sit with more lordosis, and that's why they don't feel bad when they're sitting, right? Or maybe they sit with, increased kyphosis, and that exacerbates their symptoms or something. So if they say, I feel better or worse with sitting or standing or whatever, you say, okay, show me right now so I can see. And then you as a therapist can be like, oh, I see what's going on in their back. That might be why it's feeling better, or that might be why it's feeling worse. All right, that's pretty good, guys. So, Chris. All right, capsular pattern. What is a capsular pattern of limitation?
Well, it's basically a limitation of the joint due to, could be a few things, but due an injury or pathology, but it's not necessarily related to a tendon or a muscular imbalance. The capsule itself is damaged or
So question, does it have to do with damage?
Yeah, I'm just gonna say, it's not damage, right?
It's just the natural pattern of a joint.
Correct. It's just a natural way, it's actually just the natural way a joint moves. So for example, if we were talking about the capsular pattern of the elbow, which type of motion do you have more motion with? What action do you have more motion with? Like flexion or extension? Flexion, right? So that's just a way. So when we're talking about capsular pattern, we're talking about how much motion a joint has and in what directions and stuff like that. That doesn't have to do with injury. That's just actually what the normal joint what you should see in a normal joint, how it should move, right?
Capsular pattern is actually a restriction, right? Characteristic pattern of restricted passive bone movement. So osteokinematic motion. So the capsular pattern associated with the shoulder, and it usually involves, there's more than one motion that's limited with the shoulder. So the capsular pattern associated with the shoulder is what? What's most limited?
External rotation.
Yeah.
And then?
Abduction.
IR.
Then?
Least
Least limited?
Internal rotation.
Internal rotation. So what muscle is shortest?
Internal rotation.
What muscle specifically?
Subscapularis.
Good. Number 3?
So you suspect bicep tendonitis. So what are you guys gonna do?
Speeds test.
Like what test might you do?
Speeds.
Okay. Can you describe?
Well, why don't we just talk about that first before we talk about the test?
Number 4
Okay.
hits that a lot.
So sorry, Dr. Stutz, do you want to talk about the findings first?
Yeah.
Okay.
So what did we have? Active range of motion in shoulder. What would happen with the shoulder flexors and abduction?
So during active range of motion, he was limited in flexion, abduction, and extension. But with passive range of motion, he was most limited with shoulder extension.
Why was that?
Stretch the biceps.
Well, the biceps, flexes the shoulder. So if you're putting it on extension or putting it on stretch, that's a passive test. So it probably would support the diagnosis that it's bicipital tendonitis.
Right. And active and any kind of resisted motion you can do for the biceps, the active motion that he has with flexion and shoulder flexion or elbow flexion will give you some information regarding the biceps, right? But the big thing there is what Kristen just mentioned, stretching that biceps, putting it on passive stretch.
We also said our group discussed that, like, the difference between knowing whether it could be a tendonitis or a bursitis. So we kind of said with bursitis, we would have asked the patient whether this pain is present at rest or if it's with movement or action of that particular muscle. So like if we're testing for tendonitis, we would see if the action of the biceps would be causing the pain versus if it were at rest, it would maybe be a bursitis over a tendonitis.
And it's very, very common to have both. Very common. Mm-hmm. Because a lot of times these patients, do they come in to see you right away? No. They don't come to see you right away. And eventually, by the time they come to see you, their cervical spine's restricted, their shoulder is a mess, they have bursitis, they have tendonitis, they have facet tightness. So there's a lot of different things, and then you say, oh my God, where do I start? So you always start from the beginning, right? What was the initial? What was the predisposing episode? What happened first? When did you first notice this pain? When did you first notice this pain, and what did you do about it at that time? Because by the time they come in to see you, they may say, everything hurts. It just hurts to move. And these are the people that wind up with that adhesive capsulitis. Okay?
Yeah, like we talked about in our group, it's like not necessarily what you did last week. You know, that could have been the straw that broke the camel's back. It's like, what have you been doing for, last, 10 years of your life?
Right, exactly. As we were talking, I was talking to Steve earlier, and Steve, I didn't mean to pick on you, but Steve, a problem with his shoulder, and he's probably had a problem with his shoulder for a long time, but, how often do we actually lift resisted, he's doing weightlifting and different things like this, right, Steve? At this point. So, how often, other than those people who are really truly weightlifters, how often do we put weights on when we lift up?
At the restaurant I work at, I lift the tray with the shoulder like that.
Ooh.
Yeah. And that's a heavy weight. And that's not weightlifting, but it's an isometric contraction of those muscles. Which is really
hours and hours at a time, repeated every week for months and months and months.
So this would be a perfect example. Like this, okay, you would walk into your clinic, you'd have to know what he did, right? You'd have to know when it hurt. You'd have to know what made it better. If he said, I didn't work the whole weekend, I feel better. So that's right?
Then what you tell Steve is to get a new job. You're like, sorry, Steve, you gotta...
Yeah. Or use the other arm.
Yeah.
And then the last question. What additional tests to selectively examine that contractile tissue?
The supraspinatus, I thought for sure was something that could be involved here. So our group talked about the empty cannon, and then Rod Neal mentioned the drop arm for that as well, because he is having weakness with abduction, which the biceps tendon doesn't have so much to do with that. So we have to see what else is going on. Maybe the supraspinatus is involved.
Anything else? Anybody?
Speeds test.
Speed test? Uh-huh. And I discussed in one of the groups, I said, Kyle, I think it was your group, right? I discussed, where's the biceps tendon?
In the bicipital groove, covered by the transverse ligament.
Covered by the transverse ligament. So can it sublust, or can it pop out, or can it move from that area?
Yes.
Yeah. And so what kind of a test, which we didn't do, but what test indicates that there is some instability from the long head of the bicep? Did you guys look it up? No?
Is this something, Ron Neal, is this what you were referring to with we would want to try to find a way to test if they can supinate?
No. But to answer Professor SD, can we do the apprehension test for this one or no?
No, there was a specific test to do for instability of bicipital tendon. Anybody want to look it up?
Instability.
Hold on. Type it out.
Yeah, you can literally search it in Google, and it's the first thing that pops up.
Is it Jurgensen's test?
Yeah.
Yeah.
How do you do it?
So it looks like your elbow's at 90 degrees of flexion.
This video,
I see you listen to the guy. Yeah.
Hans and Franz back at it.
Can you put it up?
Yeah, I can put it up. Yeah. Sure.
So let's watch it.
All right, let's put it. Oh, okay. We gotta. Hold on. I gotta actually share the sounds then.
But there are times
this guy should sponsor our class.
Yeah, musculoskeletal system.
Oh God.
All right, let's share. Computer sounds.
Joe.
in this video, I'm going to show you how to perform the Jurgensen's test for pathology of the long biceps tendon as well as flap lesion.
We don't see the video.
Yeah, we don't see it.
Whoops. Boo. Sorry, I stopped sharing the screen. My bad, guys. I had to. I'll try that again.
Right.
Hi and welcome back to Physio Tutors. The Jurgensen's test was primarily designed to test the transverse humeral ligament, which holds the long biceps tendon in the bicipital groove. According to a research done by Micharoli et al. In 2015, it has a sensitivity of 32% and a specificity of 88% for biceps pathology. Furthermore, a research done by O et al. In the year 2008 showed a sensitivity of 12% and a specificity of 87% for slap lesions. To perform the test, have your patient's forearm flexed to 90 degrees in full pronation and stabilized against the body. Then ask your patient to perform supination and resist the movement. At the same time, make sure that you palpate the biceps tendon in the bicipital groove. If you feel the biceps tendon popping out of the groove, this indicates a tear of the transverse humeral ligament. Tenderness or pain without the pop is indicative for biceps tendinosis or slap lesions.
Pretty simple, right?
Yeah.
Yeah, pretty simple. And sometimes you have to relocate it.
So they always mention like specificity and sensitivity at the beginning of the tests. Is that to rule in and rule out?
Yeah.
Yeah, like specificity rules in and sensitivity rules out.
Correct.
Okay.
Correct. So when we do tests, as I had mentioned earlier, they have to be based on something, right? So they'll do these tests on 1 million people, not 1 million, but several hundred people, and see how specific it is, how sensitive it is. A lot of data collection associated with doing tests, and that's evidence-based. Why are we doing it? You know, I mean, you do the same test forever and ever and ever, and it's not very specific or not very sensitive. Okay? So it might not be the appropriate test. And what we do clinically is we usually do use the test that works for us. And because somebody always comes up, believe me, with a new test. So you could find all kinds of tests on the internet, but we use the ones that have been researched and are published. Okay. All right. So I guess that's it. So it would be painful, right? If you did a Jurgensen's and you had instability, it would be painful. We're looking for pain. All right. How about we take 15 minutes? We go over one more.
All right.
Okay?
Let's do that.
All right.
So I've also heard the capsular pattern for shoulders as external rotations greater limited than, or limited greater than abduction, limited greater than